HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Associate Professor Daniel Novakovic, Judith and Louise Bale on dysphonia. What GPs need to know. Experts, please tell us about yourself.
Hi, my name's Dr. Daniel Novakovic. I'm an ENT surgeon who's trained in Australia. I have a special interest in disorders of the larynx and voice, including breathing and swallowing disorders. I did my training in this field of laryngology overseas in New York, where I spent a year and currently run a voice clinic in Sydney, Australia. I'm also the director of the voice research program at University of Sydney, the Dr. Liang Voice Program. So we have active research interests in the field of voice, and we run a voice clinic at the university as well.
Thank you, Daniel. What about you, Judy?
So my name's Judy Ruff. I'm a speech pathologist and a classical singer. So I worked for many years as a speech pathologist in the area of voice disorders, working in a multidisciplinary voice clinic and treating quite complex voice cases. I do some teaching at the Australian Catholic University in clinical education for speech pathologists, and I do some lecturing at Macquarie University in counselling skills for speech pathologists, and I do some solo work as a singer, concerts and recitals, and do workshops on voice care and to various groups.
Thank you, Judy. And what about you, Louise?
Yeah, thanks, David. So I'm Louise Bale, and I've actually worked in the New South Wales health system for 48 years. That's a lot of years. Started life as a baby nurse way back when, and then went on to become a midwife, and then moved into health promotion. I later studied social work, and I've found myself for the last 25 years working in population health. 19 years ago, I developed spasmodic dysphonia. Some said at the time that it was because I talked too much and that I'd worn my voice out. But essentially, it's been a really interesting journey, and it's a part of the health that I'd never considered until I was impacted by it. I am the founding chairperson of the Australian Dysphonia Network, where I chose to channel my professional skills for good, not evil, and set up a support network for other people living with voice disorders, and to try and advocate for a bit more awareness and understanding about people's lives when they're impacted.
Now, back to you, Daniel. We'll start with you because I've got some questions, simple ones. What is dysphonia, and which people are at greatest risk of developing it?
So dysphonia, in layman's term, is abnormal voice, and it refers to a change in the vocal quality, pitch, loudness, or effort required to produce voice that impairs a person's ability to communicate or affects their quality of life. It's a very common problem and affects up to 1/3 of us at some stage during our lifetime. The people at greatest risk of developing voice problems are people with high vocal demands. So just like a rugby league player is at risk of developing a knee injury, someone who's a professional voice user, such as a teacher, a singer, a gym instructor, or anyone who relies on their voice heavily for work, is more likely to develop dysphonia, and they are also more likely to be impacted by a change or a loss in their voice. Other at-risk groups include smokers, who have an increased risk of vocal cord cancers, older people and children who use their voice heavily.
I guess we all remember, the older ones of us anyway, the Premier of New South Wales, and I think is it Bill Clinton, who had to struggle with the change of their voice.
Yeah, it can have a significant impact, especially upon people, in the public eye.
Now, Daniel, what are the most common causes of voice problems or dysphonia?
So I'm sure all the GPs out there know that short-term voice change is most often related to viral infections, such as a common cold or flu. We know that COVID-19 can also commonly affect the voice, and these viruses cause the vocal cords to become inflamed, and that's what we know as laryngitis. Usually the voice will normalise within 5 to 7 days, and the appropriate treatment is to rest the voice. And this stops us from doing further damage, because if we keep speaking when the vocal cords are inflamed, we can cause scar tissue and permanent damage. Antibiotics are generally not required or even useful in these cases if we've just got a simple laryngitis. When the voice change persists for longer than this, or if there are no associated cold or flu-like symptoms, then it is unlikely that we are dealing with laryngitis, and other diagnoses need to be considered. So anything more than, say, 7 days, we're not dealing with laryngitis. And the layman might call this laryngitis because that's the most common cause of voice loss, but we need to think about other causes. So some of the common conditions that we see include muscle tension voice disorder, or muscle tension dysphonia, which technically is an imbalance of the muscles controlling the voice and is usually related to either inefficient technique or overuse, or a combination of both. Nodules are also well recognised by the community at large, but these tend to occur almost exclusively in younger women and children who raise their voice a lot or use their voice heavily. We don't tend to see nodules in women over 30 in general. It does happen, or in adult men. Other common problems we see include lumps on the vocal cords, such as polyps, cysts, or HPV-related papillomas, and these lumps often require surgery to remove them. Sometimes the vocal cord can be partially or completely paralysed, and this is due to a problem with the nerve supply of the larynx, in which case we would expect a weakened breathy voice, and people may cough when they're drinking, indicating aspiration into the lungs. And vocal cord paralysis is actually one of the few indications for imaging the neck and chest in the presence of dysphonia, as tumours along the course of the vagus and recurrent laryngeal nerve need to be excluded. But we like to examine the larynx via laryngoscopy prior to imaging in general, rather than just going for a CT or ultrasound scan. Other causes of vocal cord paralysis include viral infections or damage to the nerve supply during other operations, such as neck surgery or thyroid surgery, or even intubation. Some of the other conditions we see include cancer, so vocal cord cancer, and that's increased risk with age, smoking and alcohol intake. And some of the less common conditions, but also very significant impact, include other neurological conditions such as Parkinson's disease, essential tremor, and laryngeal dystonias, all of which can have significant impacts upon quality of life and can often be managed with newer treatments, including office-based injections, such as botulinum toxin or fillers. Of course, we need to consider the patient holistically, and other conditions to consider include infections, including laryngeal thrush, autoimmune conditions, age-related changes or presbyphonia, and functional dysphonias where things look okay but aren't working okay.
Daniel, how should a GP assess and manage dysphonia, and how do patients with dysphonia generally present to the GPs?
Well, generally they'll present to the GP because either they have noticed a change in their voice, so a change in the sound or their ability to function, or someone else might have noticed a change in their voice. Either a family member or a friend or someone at work kept asking them, what's wrong with your voice? Have you got a cold? And this is often one of the reasons that they present. A GP, when assessing someone's voice, needs to listen to perceptual changes in someone's voice. So listening for things like roughness, breathiness, weakness in the voice, or strain. And sometimes the GP can pick up the voice disorder. One easy test that a GP can do to look for vocal cord paralysis is to ask patients to do a maximal phonation time. And that's where we ask them to say, For as long as they can. And in a male, they should be able to hold a note, an R note, for more than 20 seconds. And it should be more than 15 seconds in a female. So if someone's maximal phonation time is less than 10 seconds, it usually indicates that the vocal folds aren't closing properly, which may occur in conditions such as vocal cord paralysis. After listening to the voice, obviously we take a history and do a physical examination. So once again, asking about recent respiratory tract infection, asking about a history of recent intubation or surgery on the neck, chest or brain, which may have damaged some of the nerves supplying the vocal cords. It's imperative to take a smoking and alcohol history because these are big risk factors for cancer. Looking for red flags such as a lump in the neck. Have they been coughing up blood, hemoptysis? Is there associated dyspnea, difficulty breathing, pain on swallowing? Recurrent aspiration pneumonia, with a voice change should really prompt, more prompt referral, or weight loss, these other signs of cancer. And it's very, very important to assess the patient's vocal demands because someone who's not using their voice for work, who might be doing more physical work and not communicating with their voice, obviously it's going to have less impact for them to have a voice change than someone like a professional voice user. And there are different factors that can lead to voice change that GPs might be able to modify. Obviously, if they've got laryngitis, we'd advise a reduction in vocal load or advise voice rest. If there's underlying causes of cough that might be affecting the voice, such as chest infection or sinus infections, the GPs can assess for those and modify and treat those. If, for example, reflux is suspected to be causing throat irritation and altered throat sensation, the GP can at least implement dietary and lifestyle changes and a barrier method like Gaviscon with alginate in it prior to assessment of the voice and visualization of the vocal cords.
That's a very clear step forward. Thanks for that, Daniel. Now, the question is, when should a GP refer a patient for specialist assessment of voice problems and who should they refer to?
Once again, it depends on the patient and depends on what the GP thinks is going wrong. But if we look to the guidelines internationally, and the American Academy has a very good set of American Academy of Otolaryngology, head and neck surgery, has a very good set of guidelines about assessment and management of hoarseness. And the evidence says that if the dysphonia does not resolve or improve within 4 weeks, then we should refer the patient to a clinician who can visualize the vocal cords, that is, perform laryngoscopy. And in Australia, this is usually an ENT surgeon. Obviously, if the patient has red flags in the history or risk factors for cancer, we should flag this patient for priority referral. And as an ENT surgeon, if you let us know that, well, this patient has risk factors, we'll see them sooner. And the way we assess the voice is, once again, we take a history, we listen, but we also perform laryngoscopy, which can be done in various ways. But essentially, we're performing an office space examination of the vocal cords. And that'll help us to uncover any overt pathology and exclude anything dangerous. However, if we do a special test called stroboscopy, where we actually flash a light onto the vocal cords, we get more information. And even if the vocal cords look normal, sometimes with the stroboscopy, which is an advanced form of laryngeal imaging, we can get more detail and make more accurate diagnoses. It's not always necessary, but it may be useful to consider when we haven't seen an obvious cause with standard laryngoscopy, or if a patient's not responding to the standard treatment and we need a more detailed look at the vocal cords, then you would refer to someone who can do a laryngoscopy with stroboscopy, and that is available in specialised centres.
A lot of our listeners will be beginning to ask themselves, who does that in Australia? So maybe if you have some links, you can send that through to us later.
That'd be fine. There's a lot of public hospitals run voice clinics, and many of the ENTs run specialised voice clinics now or have access to that equipment. In a lot of places, especially in regional or rural areas, there's a long wait for ENT surgeons. And in that case, if there's no red flags, it may be worthwhile thinking about sending someone to see a speech pathologist initially, if there is a long wait. And in fact, there are some models of care where the speech pathologist can assess the voice and then assess whether rapid referral is required based upon their triaging. So sometimes it's valuable also to involve a speech pathologist early for an assessment and trial of speech therapy, especially if there's a long wait for ENT services.
Daniel, it's important for GPs to know what we ought to do for the patients, but what should we ought not to do for patients with dysphonia?
So some of the common things we see and if we look at the guidelines, there's evidence against. Number one, antibiotics play a very, very limited, if zero, role for the primary treatment of dysphonia. So we often see people who've been referred and they've been put on multiple courses of antibiotics. First of all, it's very, very rare to get bacterial laryngitis. So unless there's a coexisting chest infection or sinus infections, the antibiotics aren't useful. In fact, they can increase the risk of laryngeal thrush, especially in people on inhaled steroids. So we advise against routinely prescribing antibiotics. Once again, we also see a lot of people who come in with imaging with a primary voice complaint. Now, if there's a lump in the neck, sure, but if we're dealing with dysphonia alone, there's really no indication for a CT or MRI scan before someone has a look at the vocal cords. And even then, unless there was a lump or a vocal cord paralysis, imaging really has a limited role. And anti-reflux medications should not really be prescribed for isolated dysphonia. So someone who doesn't have reflux symptoms in the throat of irritation, reflux itself is not an adequate diagnosis for dysphonia. So unless it's severe, it's not going to cause a voice problem. It can cause other issues and amplify voice problems, but we very rarely see reflux alone causing the hoarse voice. It can cause people to strain and cause other muscular problems with the voice and aggravate them. So if someone has a voice problem more than 4 weeks, sure, you can start them on some anti-reflux treatment, but there should always be a plan for assessment because it's unlikely to be reflux alone. And finally, on the role of corticosteroids in the treatment of dysphonia. I know that they're commonly used and some singers will request corticosteroids, but really there's a strong recommendation against the use of corticosteroids in patients with dysphonia prior to laryngoscopy. We really don't know what we're treating, and the risk is there that we'll be masking recurrent vocal fold inflammation, and the person will do more damage if we're just throwing corticosteroids at them. So once again, the best thing to do is to get someone to have a look at the vocal cords before we start treating on spec.
Thank you, Daniel. I will now move on to Judy Ruff, and I remind our listeners that Judy is a speech pathologist specializing in voice health. Judy, welcome. Now, as a speech pathologist, what would you like GPs to know or be aware of regarding voice disorders?
Well, I think voice disorders all sound as if someone has a funny sounding voice. It's not quite normal, but there are many causes that underlie that, and I think it's important to bear that in mind and not assume that it's just going to be laryngitis. Some of what I say will echo Dan's points, but that just means they're important. I think the other thing about the different causes is that those different causes require different interventions, have different prognoses, and may have many ramifications, particularly of a prolonged dysphonia or an undiagnosed dysphonia, or where diagnosis is delayed. So some causes of dysphonia are an infection, as Dan mentioned, and tend to be short-lived, but others can be related to the way the voice is used, so like a muscle tension dysphonia or a structural change in the vocal folds, for example, nodules, polyps, cysts. Nodules kind of fall into the the field of vocal use as well. They may be due to neurological disorders, so Parkinson's disease, spasmodic dysphonia, vocal tremor, or they could be a vocal fold paralysis or paresis. Each of those will sound a little bit different. Each of them will affect people differently. Each of them will have a different treatment, and each of them will have a different prognosis. So while laryngitis usually goes away quickly with no long-term ramifications, other cases may remain for an extended period of weeks or months, or in some cases, the voice may never return to fully normal function. And I think that's an important thing to remember, that we tend to assume it's going to be either pass away quickly or it's going to be cured. Sometimes people don't return to normal function and have to live with those ramifications. Some people may not even notice that they have dysphonia. And so you might be, as a GP, the first point of call, the first person to notice that there's been a change in the voice and draw someone's attention to it. That can be quite an important feature, especially if a person does in fact have cancer, where you want to alert them to it. People often will develop symptoms, though, over a period of time, and so they may not notice themselves. And people around them get used to it, or sometimes inadvertently reinforce. For example, oh, I love the sexy voice. Sounds fabulous. But actually, it's not very helpful. It's not very functional. So you as a GP can say, that's a change. Have you noticed that your voice sounds different? Are you having problems doing anything with it? Is it working as it should?
Such important pointers there for us. Now tell us, Judy, what can we as GPs do to best help our patients?
So could I just step back? What I'd like you to be aware of, because I did want to talk just a little bit more about the effect of a prolonged period of dysphonia. And I want to put you, the GP, in the driving seat, if you like. I want you to imagine if you couldn't be heard by your patients in your interviews, or if your voice disappeared after a brief period of time before you've actually finished what you need to say, or if using your voice causes you pain or discomfort. What are your patients going to think? Is he or she sick? Am I going to catch it? Are they competent? Do they know what they're doing? Because some symptoms can make people sound quite nervous or anxious. Imagine how you would feel if this goes on and on without improvement, no matter how hard you try, or in fact, sometimes getting worse, the harder you try to improve it. The constant effort makes you tired. The malfunctioning voice makes you frustrated and even wonder if you'll be able to continue in your job. A job that relies on having a functional voice. You may need to reduce your load or even change your job, thus affecting your income. You can only just get through your day's work. Interacting with friends and family is a step too far, and so social isolation becomes a very real factor. Without a proper diagnosis, you may think it's all in your head. This is something you should be able to deal with. It should just go away. And so the psychological impact can be quite high. Anxiety, low self-esteem, feelings of inadequacy, loss of control, loss of income. You as a GP wouldn't allow it to happen to yourself, but sometimes patients with dysphonia can get overlooked. Those aspects, those impacts of a voice disorder are not always noticed or taken into account.
Judy, that is such a powerful statement. I just think that any GP listening to the impact of prolonged dysphonia will now understand that it's not just a little thing, it's a huge thing for that person.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
So what can we do as GPs to best help our patients?
I think first and foremost, appropriate and early enough referral so that patients get help sooner rather than later. A failure to refer and for someone to get treatment for a voice disorder can inadvertently cause it to get worse, either because the cause of the voice disorder is related to voice use, or because a response to a voice disorder may be the development of unhealthy compensatory mechanisms, which can actually make it get worse and worse, which is why I referred to the frustration that sometimes the harder you try, the worse it might get. So that early diagnosis is really important, and that only comes with the referral. So Dan's already talked about how to make that sort of decision, GP management of voice disorders and when to refer. I'd like also to support his comments about video stroboscopy. It does give a much more accurate picture of what's actually happening at the level of the vocal folds during phonation. It can pick up problems that can't always be identified by just visualizing using ordinary laryngoscopy. And from a speech pathologist point of view, it's really helpful. It helps us to refine therapy, helps us to have a more realistic expectation of outcomes. And it's especially helpful if a problem is not responsive to therapy in a case where improvement would be expected from the initial look, or if a response is limited and it's sort of they stop responding before you think they should. And the other thing is just to probably anticipate what Louise might say. Take us seriously. Take them seriously and don't underestimate the problem. And this is especially the case if they have actually seen an ENT and been cleared of something like cancer or nodules. If they've still got symptoms, they still need help. So it is best then, that's when you might start to think, well, perhaps a speech pathologist might be a good person to refer to. And don't assume causes are necessarily from stress or personality type.
Judy, you mentioned a speech pathologist. What is the role of the speech pathologist in dysphonia, and will any speech pathologist do?
Well, sometimes even patients wonder why they're being referred to a speech pathologist. I have had them say, but why am I coming to a speech pathologist? I can talk. The thing is that speech pathologists are trained in the management of voice disorders, as it's an essential part of communication. However, as in many health professions, there's a degree of specialisation. And so for the best of outcomes, it is best to see a speech pathologist who has experience in managing voice disorders. They tend to have a deeper level of knowledge and understanding, greater confidence in diagnosis, and better skills in managing the disorder itself. This is important for all patients, but especially for people who are professional voice users, because these people have greater demands placed on their voices, and their voices are required to perform at a higher level of skill than others. Speech pathologists with an interest and expertise in voice can be found in both the public and the private system. Mm-hmm. The speech pathologists work closely with ENTs in the management of patients with dysphonia. While we can suggest a possible diagnosis through acoustic analysis of the voice and do a trial of therapy on the basis of that initial assessment, visualization of the vocal folds is essential for an accurate diagnosis and to identify any of the underlying medical issues that may contribute to a voice disorder. And so this information from the ENT further guides accurate and ethical treatment. Ongoing monitoring of progress is also important with the ENT. And additionally, speech pathologists can support both medical and surgical interventions to maximise the outcomes for the patients. What do we actually do? We analyse the voice across a range of parameters to identify any features that might be affected, and Dan referred to some of those earlier. And we look for the degree to which they're affected. So I'm talking about things like voice quality. Is it breathy, rough, strained? Looking at pitch. Is it normal pitch? Is it too high? Is it too low? Volume. Is someone able to get enough volume for their needs? Or is their voice too loud and uncontrollable? Vocal stamina. Does it last as long as it should? And also some degree of respiratory function. These features can often suggest an underlying diagnosis or confirm a diagnosis from an ENT. Along with this assessment of the voice itself, we take a detailed history to identify contributing factors in their medical history, their social history, their vocal demands, the environments in which they use their voice. We educate and explain what's going on. How does the voice work? What is a normal voice? What's gone wrong with mine? Why has it gone wrong? Is it something I've done? How can I avoid making it worse? What can I do to help it improve? We can provide that sort of education, which is tremendously reassuring for a patient and takes away a lot of the underlying anxiety that can exist. We can discuss or suggest strategies to manage the current vocal demands. Sometimes this may involve suggesting things like amplification or use of visual aids to support our communication, modifying the amount of voice use, modifying the environment so you're not competing with other noise. These might be short-term strategies while a person's voice is not functioning well, or they may be long-term strategies with ongoing symptoms and to prevent future problems occurring. And then we retrain voice use through appropriate vocal exercises to minimize injury and maximize the effectiveness of the voice, and to promote healthy, efficient voice use which meets the person's needs. For some disorders, this may be the main form of treatment, so often for vocal nodules, for people with muscle tension dysphonia, this may be the case. For other disorders, speech pathology intervention can support, as I said, medical and or surgical intervention to help maximise outcomes. We may be involved prior to surgery and after surgery to help in recovery. And finally, we provide support and encouragement throughout the process to help the patient to develop realistic expectations, to help them to manage the emotional consequences of dysphonia and to minimise the impact this might have on their recovery. Sometimes the patient might need more than we can offer within the scope of speech pathology and may need referral to a psychologist to help them to deal with the psychological and emotional fallout. And finally, speech pathologists can provide them with reliable sources of information. We know that they'll go to Google to find out what's happening and how to fix it. So it's important that we identify websites that they can connect with that can be trusted. And we can also connect them with other people who are experiencing the same or similar issues. So things like the Australian Dysphonia Network. And this is especially important, I think, for people with chronic dysphonia to get that kind of support and encouragement for other people who truly understand where they're coming from.
Judy, thank you very much for that. And now we come to the lived experience, and we will have Louise Bale, who has lived with spasmodic dysphonia for 19 years. Now, Louise, as a person living with spasmodic dysphonia, is there one thing you wish GPs understood about life with a chronic voice disorder?
Thanks, David. I think the first thing to say is that it's hard. It's certainly not something for the faint-hearted. As we've heard from Dan and Judy, sometimes voice disorders come and go and they're relatively short-lived. And most people will relate to having a period of time where they've been a bit hoarse, they've lost their voice after a big night out. But when that feeling persists and it becomes part of your everyday existence, it becomes extraordinarily frustrating. And for many people, it becomes a deal breaker in terms of their work, their ability to go to work, and their ability to socialise. Now, as Judy was saying earlier, the idea that you can put in a day's work and be completely exhausted by the end of that day to then have to go home and face the challenges of communicating with your family, that in itself is a massive challenge. And I know that, speaking for myself, it was much easier to go home and not talk to anybody. And that's it's not exactly great for family relationships. So there are so many things that it impacts on. But I think the main thing to say to a GP is if somebody expresses concern about their voice, is to take them seriously. You may not hear it exactly, or you might think, oh, there's somebody a lot worse off, a lot more sick that needs my help. But if they're raising it with you as a problem or concern, take it seriously. Don't pass it off as being stress or anxiety. Those things can certainly be part of it, but it's a little bit of a chicken and egg situation. I think if you're dealing with problems communicating, you will obviously become a little stressed, and for some people a little anxious. But to be told that you're working too hard, or you need to take a holiday, or you need to find ways to manage your stress, they might be good tips for general well-being, but they're not necessarily going to be the answer that they're looking for. As I said, don't pass it off as an everyday laryngitis. The number of people that we've met along the way in our network that have told us that it's been 12 months before a GP has referred them, and in that time they've had 4 or 5 rounds of antibiotics for laryngitis, only to find that there was actually a problem that could have been being managed much sooner. And I think the other thing, if a GP is to treat it as not serious, that they may in fact be missing something that is quite serious. And because you're in a hurry and it doesn't sound too awful, it's not a good reason to overlook it and move on.
Now, you mentioned how it's impacted your life. Why is a well-functioning voice so important?
A well-functioning voice is really important to all of us, just to be able to communicate in society, to have relationships, to function in work. Then there's obviously the people whose profession relies on their voice, so that takes on a whole other level. But just in day-to-day communication, being a social animal as we are, we need to be able to communicate effectively. One thing that's happened, I think, over the years is we've all become much more hurried, and that relates to our communication as well. So if somebody needs to put in more effort to hear you, they're much more likely to ignore you and move on. So being part of a social group and trying to make a point to have an opinion is really difficult when people are just not patient enough to listen to you. So if we want to keep people connected, part of society, able to go to work, to feel good about themselves, then their voice is super important. It's about also how much on how we see ourselves. So much of our self-identity is caught up in how we sound. And I have to say that this voice is not me. This is not the me that I know and that I relate to. And I hate the fact that it makes me sound older than I am. It makes me sound, I think, less intelligent than I am. It makes me sound like somebody that can't be taken seriously. And those impacts are terrible for your personality, but they're also terrible if you hold any kind of management role at work. I can relate to trying to discipline someone some years ago who laughed at me. And I'm sure it was because he just, I didn't have the authority. I didn't sound like I had the authority to be challenging him. So my identity was very much impacted by this feeling that I didn't sound intelligent enough to be able to speak up in meetings. So I take a back seat, and then the impact of that is that people disregard you because they think you don't have anything to say. So in short, it's frustrating, it's isolating, and for many people, it can go on to become part of a real mental health problem where people can suffer depression from the isolation. Personally, that's not my personality. I just, I have certainly had my moments, but my personality is naturally one to bounce back. But along the way, I've met many people that that's not the case. And we all know that there's enough mental health problems out there without exacerbating them by isolating people.
A very good point, Louise. So if there's one simple message that you think will resonate with GPs, what is it?
Look, I think one of the things that the network that we've formed to support people, one of the messages we say is we value our vision and our hearing. Everybody realizes how important it is to see well and to hear well, but why don't we pay attention to our voice? And it seems like such a simple thing, but it's so easily overlooked. And I think it's, as a GP, if you're able to consider that would be a big step forward, as well as Judy's story about trying to function as a doctor. And just think for a moment what that would be like. We actually have a GP in the network that I'm part of that lives with spasmodic dysphonia. And she talked about the challenges of getting her own diagnosis, even though she was a GP. She functions quite well, but she said exactly the things that Judy mentioned. People think you're sick. People think you're not confident. People think that, they should be fearful of you. And that was never truer than after COVID, when everybody was suspicious of everyone that sounded like they had a cold or had some sort of upper respiratory tract infection. So, I think it's a much more impactful thing than it could be taken for at first value.
Thank you so much for sharing your experience, Louise. Daniel, what are your key messages to GPs?
The key messages are to be aware of voice disorders, ask patients about them, be aware of the underlying potential causes, and if it's been there for more than 4 weeks, or if you're worried, send them to see one of us so we can have a look and make a diagnosis and start the right treatment. So that's the key message. Don't sit there and try and treat them without knowing what's going on. Don't throw antibiotics at them, steroids at them, especially if it's a recurrent problem. Sure, in the short term, but after a few weeks, get someone to have a look so we can get a diagnosis and implement the right treatment.
Thank you, Daniel. What about you, Judy? What's your key message to GPs?
Quite similar to Daniel. Be aware of dysphonia. Be aware of the bigger picture, the ramifications.
Mm-hmm.
Refer early rather than late so that they can access treatment and prevent a lot of the consequences that come from an extended period of dysphonia.
Thank you, Judy. And Louise, what's your key message to GPs?
Yeah. I think I agree with both what Judy and Dan have said, but I think take it seriously. Think of the whole person. Think of the impact beyond what you see in the surgery in that 10-minute consultation, and try and reflect on what that would be like if you were the person that's living with it. So refer early.
Thank you very much, Louise. And I thank all of you, Daniel, Judy, and Louise, for this very important podcast.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.